Good afternoon, everyone, and thank you so much for joining us today. We are excited to be chatting with you all about telehealth and advocacy experiences, reflecting on our lessons learned and what we think the path forward might be. This webinar is hosted by the ACCP Ambulatory Care PRN Advocacy Committee. It is being recorded as well for colleagues who are unable to be present today. With that, I will go ahead by introducing our speakers. We have Dr. Brad Winter, who practices as an ambulatory clinical pharmacist with Intermountain Healthcare in Utah at the Layton Family Medicine Center. He graduated from the University of Utah College of Pharmacy, then completed a PGY1 residency with Samaritan Health Services in Corvallis, Oregon, followed by a PGY2 ambulatory care residency with Intermountain Healthcare, where he stayed to start clinical services in a primary care clinic where he manages chronic disease states under collaborative practice agreements. Dr. Winter also has unique responsibilities in informatics, where he assists with training and development of the information systems of Intermountain Healthcare. We also have our second speaker, Dr. Morgan Stewart, who is a clinical assistant professor in the Division of Pharmacy practice at the University of Texas at Austin College of Pharmacy. Dr. Stewart graduated from the University of Houston College of Pharmacy, then completed a PGY1 residency at the Ohio State University, followed by a PGY2 ambulatory care residency at the University of Colorado. Dr. Stewart practices as a clinical pharmacist at Community Care Federally Qualified Health Centers in Austin, Texas. Her clinical pharmacy services include chronic disease state management via collaborative drug therapy management protocols. And lastly, I'll introduce myself. I'm a clinical assistant professor in the Department of Pharmacy practice at the Wayne State University College of Pharmacy in Detroit, Michigan. I completed a PGY1 residency at the Detroit Medical Center Harper University Hospital, followed by a PGY2 in ambulatory care at the same institution. I'm an ambulatory practice pharmacist in an internal medicine clinic at Beaumont Hospital, Dearborn, where I focus on interprofessional chronic disease state management with an emphasis on diabetes, controlled substance management, and quality improvement as the Director of Ambulatory Quality and Scholarship within the Internal Medicine Medical Residency Program. With that, we have our objectives described for you here. We will describe ambulatory care telehealth workflows during the COVID-19 pandemic across diverse practice sites, including challenges encountered and solutions created. We'll recognize key steps in the implementation of ambulatory care telehealth pharmacy practice from an administrative perspective, and discuss outcomes of telehealth experiences developed during the COVID-19 pandemic. And lastly, discuss institutional, local, and national advocacy initiatives to support telehealth during the COVID-19 pandemic and beyond. So while telehealth has been a trigger word over the past year or so, it's actually been around since the 1800s, and depending on the entity is described in a variety of ways. Overall, we can describe it as electronic technologies that are used to provide care and services at a distance. The Centers for Medicare and Medicaid Services actually delineate that it has to have two-way interactive communication via audio or video, although we know that other forms of communication are also allowed there. There has been a growing adoption of telehealth post the COVID-19 pandemic, whereby prior to that it did exist, but regulatory and reimbursement barriers made it difficult to adopt on a widespread basis. So the birth of the telehealth surge really happened upon the introduction of the pandemic, where there was a call for an increase in access to care, which led to the enactment of the Coronavirus Preparedness and Response Supplemental Appropriations Act, which became law on March 6, 2020, and actually lifted a lot of the restrictions and barriers that there previously were to telehealth, allowing for restrictions being lifted in terms of geographic location, types of practitioners, and the beneficiary location. This was followed by the Centers for Medicare and Medicaid Services, or CMS, expanding their telehealth waiver authority to further lift restrictions and allow reimbursement not only for COVID-related care via telehealth, but also for care unrelated to COVID-19 via telehealth. And lastly, we also had relaxation of HIPAA penalties for delivery of telehealth under good faith. So normally the rollout of this massive telehealth surge would have taken 3 to 5 years, and it happened just in the span of several weeks at the beginning of the pandemic. Now, we saw that the telehealth trends started to boom shortly thereafter. So this is a chart that demonstrates with the light blue bars telehealth provision in 2019 and the darker blue bars looking at telehealth trends in early 2020. And we can see that there was, as soon as that CMS telehealth waiver went into effect in early March 2020, we saw an increase in telehealth by 50% compared to 2019 during the same time period, followed by a 154% increase by the end of March 2020. So 50% increase in those first few weeks of March, and then up over 150% increase for COVID-19 and care unrelated to COVID-19. Furthermore, Medicare released their telemedicine services that they were now reimbursing, many of which were reimbursed at the same rate as in-person visits. So we had telehealth visits, which were focused on phone as well as video visits. However, we had what were called virtual check-ins, in which patients and practitioners could communicate via a virtual portal, and restrictions were lifted such that a prior established relationship was not required, and audits were not going to be done for that, to further expand the access that we are providing to our patients. So with that, we saw a subsequent increase in telehealth by ambulatory pharmacists described in the literature and seen by our colleagues everywhere. So establishing telehealth services as well as experiential learning experiences, while trying to also ensure multidisciplinary collaborations were not being lacking during that time. And we also have now what's called this need for teleeducation, as we expect the momentum to continue to build, and at least hope to keep this telehealth momentum building as we move forward beyond the pandemic. We've seen some innovative workflows be designed in the literature and elsewhere, where face-to-face visits were rescheduled for telemedicine visits, either via audio or video, keeping that multidisciplinary component in many situations where visits were shared by different healthcare providers to maintain that quality. And with that, I'll actually pass it along to Dr. Winter, who will start to discuss his experience at Intermountain Healthcare.
All right, thank you so much. As mentioned, my name is Brad Winter. I'm an ambulatory care pharmacist here at Intermountain Healthcare. Next slide, please. Intermountain Healthcare is mostly located in the state of Utah, as well as some of the surrounding states. We're one of the bigger not-for-profit, or the biggest not-for-profit organization or health system in the state. Representing 24 hospitals, over 200 clinics, and we see quite a few patients. Now here at Intermountain, we have a small but growing ambulatory care team of pharmacists. At this time, again, growing in the coming months, hopefully, but this time we have about 13 of us that cover 14 clinics or work with about 145 of our providers, as well as we have a whole team of ambulatory care specialists in various specialty clinics like transplant, heart failure, et cetera, as well as a PGY2 ambulatory care program. Now, for this presentation, I'm mostly going to focus on our primary care team, but the experience really tracks with most all of our AM care pharmacists throughout the organization. Our ambulatory care team in primary care, generally what we do, we focus mostly on comprehensive medication management. And how that happens is mostly we're referred patients for independent medication management through collaborative practice agreements. So with our providers, they refer them over, and we help to manage their medications and prescribe and order labs, all that good stuff. We're mostly off of a referral-based model, so we do some population health stuff, but mostly it's physicians referring patients to our services, and then we go with that. We often do what we refer to as rapid cycling models. So they'll see their doctor, then they'll see me every week or two or several weeks. until we get them to goal or until they need more robust care. So we accomplish this often through in-person visits or video visits, electronic visits, or home visits, or phone visits. We do have one pharmacist that will actually do some home visits for patients when necessary. So our story, I'm going to back it up to about 5 years ago. Right about the time I was starting with Intermountain, we changed our electronic medical record. Now, when we switched over the electronic medical record, I was one of the first AmCare pharmacists to be trained in it, and quickly found out that the initial build of the program was not well equipped for our ambulatory care pharmacists. In fact, the first training I went to was for inpatient pharmacists on how to verify inpatient orders. And I told them, I'm not going to be doing that. So they said, okay, we'll send you to our outpatient pharmacist training, which was mostly just how to find medications in a patient's chart. And I said, well, that's great, but I'm going to be doing quite a bit more. And so we ended up having to kind of start from scratch as we worked with our Intermountain informatics team, as well as the larger EMR team throughout the country, to build out workflows and schedule templates and such for our ambulatory care pharmacist team. And because we had to kind of start from scratch, as we developed it, we're able to personalize some of this stuff to pharmacists. So we built pharmacist-specific scheduling templates, as well as pharmacist-specific encounter templates. We built pharmacist-specific workflows and tools, many of which we borrowed or took parts of and kind of piecemeal together from our physician colleagues or our nursing colleagues or others, to build out what we felt was a robust and good workflow for us. Now, along the way, we were able to start to build out our telehealth processes before the pandemic ever hit, because in our organization, we were not restricted as many of our physician colleagues to the more robust rules surrounding billing. We were better able to address patients' needs and say, well, you don't have to come in physically to see me every time we speak. If it works for you better, why don't we do this over the phone or over video visit or over electronic communication? And so for the last 5 years or so, we've been building out our telehealth capabilities for our ambulatory care pharmacist team. This included building out specific encounter types for phone or video visits, making sure that we had access to and the proper privileges and capabilities for electronic communication. Our chart system has a portal for patients. We call it My Health, where patients can log in and see their notes and their labs and such. But it's also a platform where we can send and receive HIPAA compliant electronic communication. So we help patients often get hooked up into that system so that we can send and receive electronic communication if that works better for them, rather than a specific phone call or visit to me. Also, we've been very focused on making sure we can get the right information if the patient doesn't walk in the door. So we like to really push linking systems like continuous glucose monitor reports, where we can get the data even though the patient's not here, or providing patients a portal, as I mentioned, in our electronic system to send us that data along the way. So we've really been working on our development of telehealth for a while. Now, we were also along the way discussing telecommuting. Now, I want to differentiate these two. Sometimes they get a little confused. Telehealth is where the patient is not physically in the clinic with you, right? The pharmacist can be in the clinic or remote, wherever they need to be, but telehealth implies the patient's not here. Whereas telecommuting is where the pharmacist or the healthcare provider is not physically present. Perhaps the patient is in the clinic, or perhaps they're at home or somewhere else, but the pharmacist is not physically there located. The way I think of it, telehealth, patient doesn't need to wear pants. Telecommuting, I don't need to wear pants. You guys can't tell if I'm wearing pants or not right now. Anyway, as we built this out, some of the things that we had to deal with as a system and as a pharmacy team, first off, was hardware connections. Do we have the technology to accomplish this? Now, our system, as we've changed out our computers and stuff on a regular basis, luckily our pharmacy team was able to push our focus to laptops with docking stations in our specific clinic offices, but that enabled us to take our workstations wherever we needed to go. With that, we had to ensure that laptop had the right secure accesses so we could access the network and our electronic medical record wherever we were, whether we were remote or here in the clinic or maybe floating at another clinic or hospital location. We had to really consider our telecommunication capabilities. How do I call or video a patient when I'm not in the clinic, but it's still a HIPAA compliant connection? As we brainstormed and worked through various different systems, we found that if the number that pops up on the patient's phone is not the clinic number, we're very unlikely that they're going to answer the phone. And so working with our telecommunications department to set up systems where, we have a program now where I can call from my laptop and it shows up on the patient's phone as the clinic number. I can toggle different clinic numbers. I think many of us have had the experience of working through programs like Doximity, for example, for telephone, video work, or maybe even their fax feature. But all this has to be, secure. We don't want to compromise the security of our network as well as HIPAA compliant. Now, beyond that, now we got the hardware. We had to build out, as I mentioned, the templating in our electronic medical records. This included scheduling. You can see a sample of one of my days in clinic, where you can see in the details. One was a video visit. Later on, there's some PV ROVs or phone routine visits. And these were all custom built for our pharmacy team long before the pandemic. We had to discuss, okay, so the support staff. So we have what we call PSRs, or patient service reps, the front desk people that help us with a lot of our scheduling and communication with patients. Well, if I'm not physically at the clinic, how am I communicating back and forth with those individuals, and how are they communicating with me and with our patients? So we had to work through some of those complications, but they're very easily worked through. Most systems have secure messaging capabilities that can allow you instant messaging within your staffs. We also built out our charting and documentation with the thought of telehealth. And so dynamic workflows in our system, which is a workflow where I can begin, edit, and finish my documentation all while in the patient's chart, able to navigate to whatever chart information, labs or notes or whatever I need without ever having to leave my documentation. So it's all right there. Building out note templates that arrange all that information in a way that's cohesive and easy to follow. Next slide is okay. Along with that, we had to think about, okay, so we've got the technology, we're building out our templates and our EMR. Now we have to decide, how am I not only going to call the patient, and how am I going to communicate with the patient that it's going to be a telephone visit, that we're going to schedule them a specific time. How am I going to communicate back and forth with my provider team if I'm not physically in the clinic, or if maybe the patient is with the provider and they want me involved? How are we going to be able to ad hoc add me into a room and talk to the patient? How are we going to communicate with other organizations? I personally don't have a fax machine in my home. And it's crazy to me that we still rely so heavily on faxes, but we had to come up with some solutions for document management when you have those physical documents that need signatures and such. So thinking through all of those complications as you're working with your teams to build out either your telehealth or telecommuting workflows, or a little bit of both. We've also found that data collection is essential. So in order to tell your story to those who make decisions, how many pharmacists do we need? How much can you work from home versus how much do you need to be here in the clinic? We need data. Now in our system, we found that if you can find a unique speck of data that's unique to your pharmacist and you can track it, you can use that as a platform to then track other data associated with our encounters or other things. A lot of data that pharmacists do gets trapped in our narrative notes. We type a lot out and it's really pretty and wonderful and beautiful, but unless you have an extremely robust system that can translate that language, you're not going to get any data out of it. So our team, we've built this simple tracking tool. You can see a screenshot of it here, where at the end of every patient encounter, I pull this up, I answer a few questions, and then it gets saved away. This doesn't communicate out to providers. It doesn't make a new note in the chart. It just puts that data in the background so we can find it later. You can see here that we focused on kind of 4 basic pieces of data. One, we want to identify the patients in our population. That happens by signing this note. They're added into a registry. So now we can track them, track the frequency at which I interact with them. 2, you can see the top questions. I give them the setting. Was this in-person, electronic, phone, or video? Why was this patient referred to me for diabetes CPA or something like that? And then how much time did I spend? 3, what did I find? What were the medication-related issues, or as we're starting to call them, MTPs, medication therapy problems that were identified? And 4, what did we do about it? What were some of the actions or recommendations? Now, this form has gone through a few iterations, and it's going to go through a few more as we adapt to the different challenges our team sees. But that's how we've been tracking our data, at least over the last year. So let's talk about 2020. Let's talk about my experience in the last year. So before 2020, as we mentioned, we've been kind of working on telehealth, and we were beginning to work on our telecommuting process. In fact, at the beginning of 2020, after we launched our data tracking tool, we planned to pilot a small telecommuting pilot where our pharmacists would be allowed to work 1 to 2 days a week remote, starting in the beginning of March. Well, fate had a different plan for us. And the beginning of March, instead of 1 to 2 days, we had a massive pilot where we were told everyone go home and never come back, essentially. So we transitioned along with many of our other healthcare colleagues to working remote. Now, I will say that, you can go to the next slide. Thanks to our experience, thanks to all of the work we've been putting in over the last 5 years, our transition in pharmacy was actually pretty smooth. Our clinical tracking tool was able to demonstrate that for us. We'll look at some of that data in a minute. And really, some of our pharmacists were some of the first to be able to use things like our new video visit platform that our system has adopted since. Throughout the pandemic, we're able to continue to ensure access to our patients through video and telephone visits. Electronic messaging, as I mentioned. Now, in the last year, we've improved that system in our system with an app that the patients can use instead of just the online portal. Continued our work to make sure we're linking CGM and clinical reports. And then as well, we found that sometimes we need some physical data. We need blood pressures, we need labs, we need an INR. And so we've worked with our community pharmacies, our hospital and clinic practices to try to build some walk-in data collection processes. A lot of my patients, they can walk into my clinic without an appointment, just go to a desk and say, I need a blood pressure check. They check their blood pressure, check a few of their other vitals and things, ask them some questions, and then the patient leaves, and they know that I will be communicating with them electronically within the next 24 hours. Our anticoagulation clinics, they had a drive-up INR process that we've been working on in the last year. So patients can drive up, get their INR, and then they can head off, and we can communicate with them through telehealth. The next slide, please. Through 2020, we were able to show that we touched the lives of over 6,000 patients, over 16,000 times. You can see here that the majority of our referrals were for CMM, or comprehensive medication management. That's our actual medication management. We had, also some comprehensive medication reviews, transitions of care stuff, drug information. Of all of that stuff, you can see here that we identified a lot of adherence problems over the last year as patients were fighting to get the medications they needed even through the pandemic. But we also had about a quarter of the issues we dealt with were safety. So inappropriately dosed meds, drug-drug interactions, adverse events. About a quarter was efficacy. So that's you're not at goal, let's increase your insulin, let's increase your blood pressure, let's increase your INR or whatever. And then indication. So we had a good portion of patients we identified where we found that you're not on the right drug, or you're missing a drug, or maybe you're on too many drugs. And so let's fix that. Next slide, please. But the most interesting to our leadership was that even though we saw a little bit of a dip as the year started, as the pandemic was kind of starting to hit the news in February, you see that the dark blue line at the bottom, our in-person visits went down to almost nothing by April. But we had a corresponding spike in our telehealth visits. And overall, our monthly average of patients that we saw went up throughout the year. So we're able to show that our AmCare pharmacist team was able to maintain and even increase our efficiency throughout the pandemic. Before 2020, we had about 75% telehealth. So we did a lot of telehealth already. By the end of the pandemic, we were doing about 90% as our in-person visits started to climb up a little bit again, as we improved our safety features in our clinics, and as well as numbers have been coming down in our area. Next slide, please. So some key points from all this, if I could share anything, work on your EMR, work with your informatics team, build those relationships both inside pharmacy and outside. Providers, nurses, educators, dietitians, they all have workflows, and maybe some of them have some tools that you could apply and use in your practice. It's very, very difficult to make big changes to a large EMR. So use what you have, learn what other people do. Focus on your communication platforms. How can you reach out to patients either from your office or from your home? And then think about what resources there are, what clinics, hospitals, community pharmacies you can partner with or that are associated with you that patients can use in order to communicate with you. And then last, tracking data is so powerful. Our AmCare team is able to grow within the pandemic because we're able to show how we maintained and actually grew in efficiency. Next slide, please. And then my last slide here, all I want to say is, our experience here at Intermountain is continuing. We are going to continue to change and adapt. Now that we've been through the pandemic, we're left to think, what is the appropriate workflow? How much should I be in the clinic versus can I be telecommuting? We actually conducted a recent survey of our providers, and at the end of as of I think a month or 2 months ago, about 90% of the providers we work with rated the pharmacist most valued when physically on site. So there's still a lot of pull for us to be in the clinic, but we don't necessarily have to think of ourselves as only in the clinic. We have strategies that we're building out to utilize telehealth and telecommuting to expand to rural areas of our state. Utah, where you saw those dots on our map earlier, that's where most people live. But there's still people down in the South that need our help, even though it may not justify sending an entire pharmacist body down to that town. We're going to increase our focus on appropriate office space. Okay, we can work remote, but do I have the right office equipment? Do I have the right connections and broadband? We need to make sure we're supporting our pharmacy staff in those places that they're working, wherever they may be. And then lastly, of course, we are going to continue to refine and develop and modify our EMR tools. We're going to continue to work on bridging the gaps that we see with our patients and improving our efficiency and documentation. But that's what I wanted to present today, and I really appreciate your time.
Wonderful. Thanks so much, Brad. I'm Morgan Stewart, located here in Austin, Texas, and looking forward to sharing my experiences navigating telehealth over these last few years, which has definitely increased in recent history amidst this pandemic. I'm thrilled to be here at Community Care, or CUC, and share my perspective of all the work they've done in getting telehealth services set up in the pandemic hit. So Community Care was a little bit different from what Brad talked the site where prior to the pandemic, we were almost 100% in the clinics and then had to rapidly transition. I've been with Community Care now for about 9 months, but I'll also be sharing some of my lens from a previous institution prior to the pandemic where there was a little bit of a mixed model of both telephone and in-person visits.
Dr. Stewart, I think you might have a little bit of static there that we're hearing. I don't know if it's just me, so I'm not sure if maybe you're too close to the microphone or something of the sort. We'll give that a try.
Let me try one thing. Is this any better?
I think this might be better.
All right, please keep me updated if you see anything happening again. All right, how about now? Is everything still good?
Yes, everything's great now.
Thank you for letting me know. So Community Care is an FQHC, or a federally qualified health center. And it's, oh, you can go back one slide there. There you go. It's servicing the city of Austin, which is Travis County, and it's this huge network of clinics, mostly patient-centered medical homes, or PCMH models, and we provide care to our medically underserved and vulnerable patient populations in the area. There is relatively high percentage of patients with no medical insurance, And our clinics provide most of those safety nets to individuals in need. As an FQHC, we have a plethora of services available to patients, including both primary care services. We think of dental, our specialty services as well, things like endo, women's health. We have a Hep C clinic, pulmonology, podiatry, recently added, as well as hepatology. We have a full in-service pharmacy, which is in-house, that does have a 340B program, which is a super valuable tool in helping bridging those gaps with medication access. And most notably, a clinical pharmacy team, which I am a part of. Our clinical pharmacy team is continuously growing, both figuratively and literally, as one of my colleagues was just out on maternity leave, but we also have a full-time PGY2 ambulatory care resident. And a lot of us are wearing multiple hats, with some of us being, let's say partially employed by a university, as the case with me, but also some admin roles. So between all of us, it equals out to about 10 FTE of clinical pharmacists providing patient care services. I'm actually located at one of the larger clinic hubs that serves as a training site for multiple medical residency programs, things like our IM residency, and as well as our family medicine residency program through UT Del Med. And so because of this, we do see a lot of layered learning in those clinics. As of right now, each of our, you can go back, there we go. One slide back. There we go. As of right now, each of our pharmacists are on site about 60% of their time, and we work remotely the other 40% of our time. The main focus we have is on disease state management, with an emphasis on those cardiometabolic disease states like diabetes, hypertension, hyperlipidemia, and a little bit of anti-coag here and there as well. But we also have all of these other protocols in place to manage the other disease states listed there for your reference. As of right now, we're not billing for any of our services, but instead showing value through our quality metrics. And we're providing these services either in one-on-one visits with patients, so both face-to-face as well as telehealth. And our telehealth can be both phone or video visits. But we're also providing co-visits with our collaborative care team, or our lingo here we use is CCT. So our collaborative care team includes individuals such as physicians, nurses, medical assistants, clinical pharmacists, dietitians, behavioral health counselors, community health workers, as well as a care management team. And I'm honored to work with such a diverse team to provide that comprehensive care to make sure all aspects of patients' health are fully addressed. So I mentioned, right, that we're on site now 60% of the time, and 40% telecommuting, but that was not always the case. So prior to the pandemic, almost all of the services, you can go back to the next slide. So prior to the pandemic, almost 95% of the services we offer to patients were done in person. And as you can imagine, of course, during the pandemic, that rapidly changed. And we had a fabulous PGY2 resident at the time, who is actually now was hired on afterwards, is now my colleague, Chelsea Roscoe, put together this amazing business plan, similar to what Dr. Winter presented earlier, but it outlined a lot of those things like background literature review, different things of as far as benefits and barriers to telecommuting services. Because there was a huge pull to try to gain clinical pharmacists back on site, but we were able to show a lot of the benefits, right, of allowing our pharmacists to stay portion on site and portion in telecommuting. We're actually in the process, so that the plan that she proposed was supposed to be in place for a year to see kind of how things went. We're actually in the process of submitting another proposal to make sure that that telecommuting stays in place for the foreseeable future. So anyways, during this rapid switch to telehealth services, we started utilizing this platform called Doxy.me, and that was a secure platform that we were able to do video visits. And then we have a virtual phone line, similar to Dr. Winter mentioned, that it looks like you're calling from the clinic, but it's actually a web-based phone call that's occurring. However, As of 2 weeks ago, we actually transitioned to Epic, which has its own video feature integrated into that system. But the phone calls are continuing to occur via that virtual line. I might be preaching to the choir here, but we really have seen so many benefits with telehealth. From a clinical pharmacy perspective, because we're not billing, it really doesn't matter how the visit is being conducted, whether that's face-to-face, whether that's via video, or whether that's via phone. So we think from a patient access perspective, if there's transportation barriers here, so many of our patients are not able to, they either don't have a car or unfamiliar with the bus system. We also think about patient schedule, as a lot of individuals did lose work during the pandemic. And so, they tried to pick up as many hours as they could. So their schedule was a little bit more variable than other times. All of those things correlate to indirect costs. We think about from a provider efficiency standpoint, the commute, right? Austin is already a hugely, lots of traffic in the area. So the commute definitely was a huge hit as far as our clinical pharmacists telecommuting. Having, sufficient space. So we think about all of, with all of those collaborative care team members being at a clinic, a lot of times there's not enough sufficient space in the clinics to conduct visits. As well as just being more efficient of uninterrupted work when you're looking at the clinic and there's so many phone calls coming in or someone stopping by asking curbside. Sometimes doing the one-on-one visits in a telecommuting model, so being at home, you get a lot more interrupted work done. And then during the pandemic, right, having less people on site had preserved PPE, social distancing, as well as wait times associated with individuals at the clinic. You think of all of the patients being referred to clinical pharmacy are also high risk, with things like diabetes. So less waiting time in areas that there could have potential exposure to communicable diseases, as well as COVID. So additionally, not only from those perspectives, but also from an objective outcomes benefits, I have outlined here some benefits as well that we saw during the telecommuting and telehealth implementation. I'll orient you to this chart. So if you look at that top picture, it's a quick look at our productivity. Right now, the productivity is being measured as a number of direct patient care encounters provided by all of our clinical pharmacists for a specific month. So you'll look there, the month is on the x-axis, and then the actual values are on y. The fiscal year 2019 is in a yellow line, and then the blue line is actually 2020. That red dotted line, I'm sure you can probably just barely see it, is actually the internal goal developed based on previous productivity data. And as you can see, as that transition happened, we call right around March 2020, there was some peaks and dips in the first few months. So looking at, kind of March, April, May, but productivity plateaued soon after that. And you'll see that the clinical pharmacy productivity remained above goal for 2020. And it was either maintained, if not exceeded, from the year prior with the same amount of FTE. And so you can imagine, as people kind of got in the flow of things after around May time, we saw a huge advantage there of allowing telecommuting as part of the clinical pharmacist workflow. Likewise, on the bottom figure here, the number of interventions was consistently above goal. The clinical interventions that we're tracking are things similar to how Brad mentioned, but things like starting a new medication, ordering necessary lab, to ensure things like safety and efficacy, typical things that you would think of as far as a typical clin pharm intervention. Even with all those successes, of course, there's barriers to telehealth. We think about in our environment here, so in an underserved setting, we have a lot more complexity when providing patient care, especially when pursuing things like video-based appointments. For one, technology has been a pretty big rapid learning curve for our patients to handle. Whether it's the fact they're unfamiliar with that technology or the platforms aren't available in their native language, or they may just not have great access to smartphones or computers. Likewise, there's been a lot of mistrust in telehealth visits that we've been experiencing. And we've seen patients being fearful of the security of visits. Maybe someone's watching in, or just not trusting that security. I've also had many people report to me that they didn't want to turn on their video or do a video type visits because they were just maybe a little embarrassed by their home environment. Likewise, of thinking of things like had a few patients in domestic type situations where there's no privacy to talk openly about kind of things that are going on related to their healthcare. A simple solution we've been able to get through with that is just developing a rapport with the patient and being okay of not, in a video visit, yes, you get a lot of those kind of nonverbal cues, but being okay with a telephone visit. You can get so much from the patient by some of those, walking through with a patient over the phone what they're doing. So if they don't know the names of their medications, like, okay, let's walk together over to where you store your medicines. Where is that, by the way? And there right then you get to kind of get a little bit of insight of where they're storing medications. Or let's say they don't know, they haven't been checking their blood pressure. All right, well, let's walk through it together over the phone. Walk me through what you're doing, and you can kind of provide that feedback, right? If they're checking their blood pressure appropriately, but also you get a vital reading out of that as well. From a site perspective, another challenge we consistently faced was inconsistent communication. We had so many frustrations between provider, but also our patients with these incorrect alerts going out to patients who they were under the supposition that maybe this was a phone visit, but it was actually in person, or vice versa. And we also had just patients who just had a habit, right? Even if they got a correct alert, they knew, hey, I have an appointment, this is in person. And so likewise, I alluded to this earlier, but sometimes there wasn't enough space to provide those adequate privacy for a telehealth type of visit. So one thing that we don't have as clinical pharmacists is dedicated support staff, right, to troubleshoot some of that technology. And so sometimes, unfortunately, we were spending half of our time on those non-patient care related items of troubleshooting through that. One thing, solution that we came up with here is honestly just communication and advocacy. Ensuring your IT has the correct communications listed for your specific appointment types. Also, never underestimating just how much even going just an extra couple of seconds at the end of a patient appointment to let them know, hey, remember, our next appointment together is phone. Sometimes that quick reminder can also be really beneficial as well. And advocacy, ensuring that your key stakeholders know what challenges you're going through. Nothing can be done if people aren't informed of what's going on. So taking those screenshots of errors that occurred, marking down how many people are showing up at the wrong dates and times, and just being very specific about what your needs are and coming prepared to some type of meetings with admin or IT with potential solutions. Lastly, I'll touch base a little bit on here, but running into the problem of home monitoring, you can't exactly titrate medications without having some type of objective data to base your pharmacotherapy plans. So we have a lot of patients who aren't able to either afford home monitors or they can't troubleshoot some of those errors. And we actually were able to start a pilot here using our internal pharmacy to be able to provide blood pressure cuffs to a select group of patients who had the county's medical access program coverage, and as well as expand coverage for CGM devices through our specialty teams. And all of these things started as a small pilot that we were able to kind of, generate some data, and we got to see some of those quality metrics start to bend as we improved our access, right, for our patients to get these medical devices. And so with that, we were able to really expand how many people are getting access to, whether that's a free blood pressure cuff or coverage of a CGM. And then I can't stress enough how important an initial in-person meeting can be very helpful. A, to develop that relationship, B, to set those expectations, and C, just make sure that the patient is a good candidate for telehealth-based care. In the interest of time, I won't go too far in depth on this slide, but just kind of as an FYI, we, as I mentioned, do a lot of team-based care. And when the pandemic hit, there was a big question around how are we going to ensure patients are continuing to receive that same quality care from our collaborative care team in a virtual environment. So we had some great group of students doing this quality improvement project that looked at the different facilitators and barriers when it came to team-based care. So you'll see there at the bottom, things that really played a good role as far as facilitators for team-based care in a virtual environment, including that it's just more efficient to conduct telehealth-based visits. There was reliable technology was found to be another facilitator. And then individuals who were very efficient at these virtual team-based care visits also had a self-reported baseline, pretty good comfort level in using that technology. And barriers, however, that many teams experienced were not having enough training, as well as where the specific location of the collaborative care team was. So, for example, it's probably a lot more efficient, right, to turn around and talk to your colleague versus trying to figure out where are they in a virtual environment, calling or sending them instant messages, and then not having adequate support staff to kind of have some extra shoulders to lean on also impeded some of those team-based care. And before I hand off to Dr. Mohammed, I'll briefly touch on the importance of internal or institutional-based advocacy. I guess it cannot be overlooked the importance of talking with our key stakeholders to increase their awareness and challenges of pharmacy practice. I know a lot of times we'll get into our own bubbles and we're like, gosh, everyone knows we can't bill, or everyone knows we don't have adequate support staff. And it kind of surprises me every time, I have to take a step back if I'm just chatting with a provider or administrator in our clinic and they have this like, wait, what? Wait, what? You're not billing for services? Or wait, what? And so just even something as simple as forwarding along a email chain, right? That's like a letter writing campaign that they can quickly, check the boxes and send off and support, because our medical providers are a huge asset when it comes to advocating for the needs of pharmacy practice.
Thank you, Dr. Stewart and Dr. Winter, for sharing your experiences. I'm going to spend just a few minutes talking about telehealth advocacy updates and some of the next steps that we anticipate. So while we have seen a surge in pharmacists providing telehealth services, we do know that there are some limitations that we have to overcome. First is that pharmacists are not listed as providers under the CMS telehealth waiver or under the Coronavirus Preparedness Act. We still are listed as auxiliary personnel, which limits the type of billing and services that we're able to provide. We still are providing services incident to a physician, meaning that the physician has to submit the bill on our behalf ultimately, and that CMS does require direct supervision instead of general supervision for telehealth services. Although direct supervision has been allowable in a virtual capacity by CMS, however, general supervision would be preferable to direct supervision. The other concern is that the flexibilities and authorities that have been granted to pharmacists under the public health emergency ultimately expire when the public health emergency expires. And therefore, the goal is to advocate to make these key flexibilities and authorities permanent beyond the emergency. And the entities that have the power to do this are ultimately our federal agencies, such as the federal and state government, the Department of Health and Human Services, CMS, as well as the FDA. We have multiple pharmacy organizations now that are taking on initiatives for advocacy, and the American Pharmacists Association has what's called a coronavirus watch, and they actually describe that telehealth is now a new frontier for advocacy, and we can use our collective efforts across organizations to advocate and to move forward these temporary changes to become permanent. So if you go to the APHA advocacy website, they actually describe a variety of advocacy opportunities related to COVID-19, and one of them is focused on telehealth. They also provide what the talking points are and what are the ways to engage our legislators, but also become more engaged ourselves in telehealth. And specifically, the focus is on codifying these recent flexibilities and expanding them under Medicare and Medicaid such that they permit and reimburse pharmacists to provide services the same way as we do for in-person visits beyond the emergency. ACCP also has a legislative action center where we're able to view a variety of federal and local campaigns. They actually have a section where you can find legislation specific to certain key terms, as well as find your local official. So when I went ahead and searched telehealth legislation, 85 bills came up. So you can see it's been building a lot of traction. And most of these bills, for example, the Telehealth Modernization Act, the Keep Telehealth Options for 2021, Ensuring Telehealth Expansion, so on and so forth, they all focus on trying to make these temporary flexibilities and loosened restrictions permanent beyond the pandemic. You're also able to type in your zip code and your address and find your federal officials and compose a message. And we'll talk about what the power of that is. I know sometimes it seems a bit challenging to make progress that way. Furthermore, we also have a joint pharmacy organization statement on coronavirus policy recommendations. So a variety of organizations have come together, pharmacy organizations from a variety of different practice settings, to ultimately create recommendations on a variety of coronavirus issues. One of them is focusing on reimbursement for services by removing barriers, specifically allowing pharmacists evaluation of medicine services under incident to physician arrangements to be delivered under general instead of direct supervision, and also to allow pharmacists to bill directly to Medicare Part B for telehealth services within their scope of practice. So this might sound a lot like the provider status push to most of you. And as we look at telehealth as this new frontier for advocacy, we hope that perhaps narrowing our efforts to telehealth billing might be a good starting place, since we know the challenges that come along with the greater provider status push. So a successful example of advocacy during the virus is related to diabetes self-management training programs, or DSMT. So in August 2020, it was actually authorized that DSMT could be provided via telehealth. However, the language did not include pharmacists. So therefore, the Association of Diabetes Care and Education Specialists advocated with some of the national pharmacy organizations to incorporate or to advocate for pharmacists to be included in that verbiage. And that push ultimately did lead to pharmacists who were part of an accredited DSMT program to be eligible providers under that language. And how they did it, they did that by sending letters to CMS. Over 700 diabetes care and education specialists sent letters. So these grassroots movements actually worked. Submitted comments through the CMS formal rulemaking process, which is a public way to actually comment on bills that are coming through. They raised the issue with the CMS waiver and COVID team, and Congress is now considering making this a permanent telehealth expansion beyond the pandemic. So what's beyond the pandemic? We have seen bipartisan support of such acts as the Connect for Healthcare Act, which actually will waive these restrictions, such as geographic restrictions for services in high-need health professional shortage areas during national emergencies, but also outside of national emergencies. What needs to happen is that Congress needs to change the law. They need to change the Social Security Act, and we have already seen movement in this direction. So Senate introduced some bills, as well as the House, addressing a variety of these access issues beyond the pandemic. So what can you do? Be aware of these bills. Be aware of where they are in the process. Grassroots movements and letter writing actually does work when there's enough traction. Consult your Center for Connected Health Policy for telehealth changes in your state, which I'll show you on the next slide. And given the challenges with advocating at a federal level, advocating with state payers and commercial payers is a key. And my colleagues already discussed the importance of documenting and collecting data. So the federal, state, and so the Centers for Connected Health Policy actually provides federal and state telehealth updates. So I actually entered Michigan, which is where I practice, and I can see what some of the emergency actions have been. However, you can see that they will expire 30 days after the state of emergency for some of them. So we have to be mindful of maintaining this traction beyond that time. So lastly, contacting your elected officials is important. You can do so easily by going to usa.gov/electedofficials and finding both federal, state, and local officials by simply clicking a button and entering your zip code. And of course, we have to do everything COVID-19 style virtually. So just some tips if you are attending virtual legislative meetings, knowing who you're speaking with, is it the legislator or the aide, knowing the bill, giving your examples, and then reaching back out to the professional organizations to let them know which bills have support or opposition by your representatives. So with that, we do have a few minutes for questions. I have seen some come through the chat, so I'll actually start there and hopefully we can get through them. I see that some of the questions originated back to Bradley. Bradley, is this intervention tracking part of the clinic note or completed separately from the note? Oh, and I see that Bradley did answer that it's completed separately. Let's see. I see that we have.
I can speak to that briefly if we want. Just that we write out our note, and this piece was separate, although it's built into the same system. So when I click sign on my note, all I have to do is in the same system, click on one thing and that form pops up. We fill it out, we sign it. It does not create a second note. It doesn't actually create any visible documentation in the chart. That's what my narrative note does. What it does is it just saves coded data in the background that then our reports pick up afterwards.
Awesome, thank you so much. I see that most of the questions have been answered in the chat, or all of them by our speakers. Are there any additional questions from the audience that are lingering? You're welcome to turn your mic on or put it in the chat. All right. Well, we may have had all of our questions answered. Thank you all for attending. We hope that you're able to take back some of these tips to your practice, and we wish you the best of luck with your telehealth endeavors as well.